Good afternoon, everyone. It's October 10th, 2023, and we're here for a special board meeting. And Supervisor Campbell, would you lead us in the Pledge of Allegiance, please?
I would love to.
Thank you.
Please rise. Ready, begin. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Okay. So during special board meetings, we do not have the original oral communications, but I kind of like to set the tone for the meeting in that I remind people that when we do have public comment on the one item that we have before us today, we're all respectful and also kind. And towards that end, I usually, every meeting, pick a quote from somebody either from history or current day. This particular quote comes from a current day person that you probably have heard of. Let's see if I can find it here. Her name is Maya Angelou, American poet and civil rights activist. And here's what she says. Continue. Continue to be who you are and how you are, to astonish a mean world with your acts of kindness. And with that, we'll go to our presentation that we have today. And Heather, would you please read that appointment?
1:30 p.m. presentation on the state of the opioid epidemic in Tuolumne County.
Do you have? Okay. Yes, you do.
Does that work?
Yeah.
Can you hear me? All right. I know I can get to the room, but the people online want to hear me too. So thank you. I'm Health Officer Kim Freeman. I'm here with Sheriff Bill Pooley to talk to you about some updates with the opioid epidemic over the course of the last year. We gave a similar presentation last July, and we have some new data to share with you. So just a reminder, narcotics are a class of medications that encompass anything that is involved with sedation and pain relief, slows down breathing and your GI system usually, and that's where it becomes fatal, is the slowing down of the breathing. Where it becomes addictive is the euphoria. And so what we're working against is the fact that these medications, which are used for appropriate reasons many of the time, have addictive and lethal properties. You may hear about opiates and opioids. In reality, they're used interchangeably, and that's totally fine. It is not a grammar faux pas. However, technically, opiates are the natural chemical from the natural opium plant that includes morphine and heroin and codeine. But opioids are the synthesized ones, like Percocet, like hydrocodone or Norco, and like fentanyl. Unfortunately, I don't have a whole lot of updated data from 2022, but I do have data from 2021, which didn't look any different than the 2020 data I presented last year. We are the first in the state per capita for morphine milligram equivalents prescribed, the number of residents who are prescribed more than 90 morphine milligram equivalents, the number of residents on opioid and benzo co-prescriptions, which is dangerous because both are a class of narcotic and both depress the respiratory system. So together, their overdose rate is higher. We're the highest for prescription opioid OD hospitalizations and the number of opioid prescriptions per capita. We are second for any opioid-related hospitalization. We haven't always been number one. We have been number one for about 5 years in most of these things. But about 12 years ago, we were third, fourth, fifth, sixth in these same things. You'll see some data that shows we have improved quite a bit, but the rest of the counties are improving faster. And that's how we've elevated to, part of the reason we've elevated to number one. And why are we here? As a reminder, there was a lot of things that happened that created the environment that doctors wanted to prescribe more. Not because they're bad people, but because the environment was such. One of these things was the fifth vital sign. It became a big push that the pain was the fifth vital sign, in line with respiratory rate, blood pressure, pulse, and temperature. All the other ones can kill you. Opioids and opiate withdrawal cannot kill you, but it was the fifth vital sign. So nurses would ask the patients for everything, how bad is your pain? And come and tell the doctors their pain is so bad that you need to do something. So this created an environment where doctors were wanting to prescribe more. Drug companies falsely portrayed that these medicines were not addictive. In my own medical school at UCSF, one of the best in the country, somebody came into pharmacology class and told us, you won't create addicts if you prescribe for pain. And that was about 22 years ago. So it created this environment. All these other docs were being told this. I personally was working on the ambulance at the time, so I had some evidence to tell me that wasn't correct. We were using Narcan back then, but not every doc knew that, and they went in believing that. And then there were lawsuits in the 90s. These lawsuits sued for underprescribing. You shouldn't have any pain. You should be very comfortable. And so they won. The lawyer, really the lawyers are the winners. They won, and the doctors had actions against their licenses or patients who wouldn't come to them. All of these things created an environment where prescribing became very, very high, not just here. Since I've been here, in 2006 I've been told by many, many, many of my colleagues, our population is different. We can prescribe more because of X, Y, or Z. X, Y, or Z being that we have more of an elderly population or more of a disabled population or our cancer rate, our cancer center. All of these things are true that we have higher populations for some of these, but it is not a good reason to prescribe more. And I'll show you how the other counties with high rates are prescribing. Here is our cancer incidence, a few years ago. You can see our triangle-shaped thing just to the right of Stockton there. That's Tuolumne County. We're light purple, which means we're kind of high-medium for cancer rate. We're not highest. But look at this map. You'll see some other maps, and you'll see where the high prescribers are. We're not the highest cancer rate. That's the important thing to get here. This is a graph done of morphine milligram equivalents per resident. Oh, and let me explain that. I'm sorry. Morphine milligram equivalents are how we equilibrate different medications. So it's, how much Percocet is worth, how much Norco is worth, how much methadone. That's morphine milligram equivalents. So a Norco 10 is 10 morphine milligram equivalents, and Percocet 10 is 15. And it goes on and on. You can do the calculations for all of them. There's a table online. You can just put them in. Any practitioner can do this. The important thing about this, morphine milligram equivalents, equilibrates it. Last year, the FDA or the CDC put out guidelines that said that anybody above 50 was at higher risk for overdose, higher risk for complications, and didn't have better pain. This is really important. Before that, it had been 90, and that's why some of these graphs say 90, because everybody's been looking at 90. They changed it by almost half, and so we have the highest over 90, but we also probably have the highest over 50. Why wouldn't we? So anyway, this is morphine milligram equivalents per resident in 2020. It's 2020 because that's when we have the last accurate census data. So I took the state data and the census data and graphed the 14 counties with age percentage over 20% of a population over 65. So basically, these are your counties that are the eldest. 65 is used because that is the data that's available, not because I thought that was a good cutoff, but that's the data that's available. And you can see we're kind of in the middle of that age range, but we're highest for prescribing. Right by us is the lowest prescribing, down at the bottom of that plot. And there's no way to draw a line through that that would make any sense. Same thing here. This is MME over 90 per 1,000 population. Graph looks the same. We're the highest prescribers, but we are not the oldest. 2019 was the last year I could get data for all 58 counties and their disabled rate. Yes, we have a higher disabled rate. State average is 10, we're 20. We're not the highest, but you can see that we kind of stick out there. In 2019, about 1,000 morphine milligram equivalents per resident, higher than the rest of the trend. In 2021, I could get 44 counties, but you can see we stick out even higher now. And Calaveras is right next to us. And this is despite the fact that we have come down to 800 instead of 1,000 for the average then. This is a pretty impressive graph here. This is your risk of becoming addicted with even just a few days of prescriptions. It's normal to prescribe after surgery, a broken bone, things that are painful. This is normal prescribing. Nobody's doing anything wrong or out of scope of practice to prescribe 5 or 7 days, which has kind of become the norm. It used to be 15, 20, even 30 you would get from surgery a couple of decades ago. The dotted line there is 3-year probability of being addicted. At 5 days, you have almost a 5%, a 1 in 20 probability that you're going to be addicted 3 years later with just 5 days of post-surgical pain medication. It's higher at 1 year. About 10% of people 1 year after their surgery or their other painful procedure will be addicted. And if you get more, 10 days worth, you're about 20% likely to be addicted at 1 year. That's a lot. This is our morphine milligram equivalents per resident in Tuolumne County versus California. Tuolumne County is blue and California is orange, 2010 to 2021. We were at 2,500 in 2010, which is the equivalent of every single resident of this county getting 250 Norco 10s a year. Even the age 6 months, every single resident, that's the equivalent. And we were not the highest. We were third back then. That was the trend. We've come down to about 800 last year, or 2021, I'm sorry. California, though, the average in 2010 was about 660. We're not even down to the state's average in 2021. Lots of improvement, but not where we should be. This also shows our morphine milligram equivalents by patient location for prescriptions in our county. The yellow line at top is ours. The red line is California average, and then everybody else is in between. In the top 5 counties are motherlode counties. We have Tuolumne, Calaveras, and then fourth is Amador. So that's pretty impressive too. This is really a regional problem, not just us, but really regionally here. And we don't have any reason to do that. If you look at the other counties, I know you can't read them, but we have, San Joaquin and San Bernardino and some counties that are high ag rates, high industrial rates in the middle, but they're not prescribed per capita more. So the industrial population or the working population, that goes out the window as far as evidence there. And here's a map of where these morphine milligram equivalents by location are. Here, our darkest is Tuolumne County. Right above us, Calaveras is pretty dark, but they were in the 700 range. And Trinity, which was third among the top 5, they're in the 700 range as well. This is the overlapping opioid and benzo rate per 1,000. Again, we're worse in the state per capita for this. As you can see, again, we're trending better. Still not down to the 20 average that the state held in 2010. Now it's about 7 or 8. We're up above 30. Or I'm sorry, up above 20. 22 is where we are now. And this is what that looks like. Same, it looks the same as the others, that we have this problem affecting multiple facets of the opioid epidemic. This one's alarming. It's not coming down, it's going up. These are the opioid-related ED visits, again, per capita. Blue line is Tuolumne County, and orange line is California. It's going up everywhere. A reason for this is the fentanyl introduction into the supply, but also COVID is hypothesized to have had a pretty good effect on whether people were using addictive substances versus the other things they would have done during those times of lockdown. So who is overdosing and going to the ED? This is preliminary data for 2022 per 100,000 residents. Along the bottom there is 5-year increments, so it might be hard to see in the back, but we got less than 5 years old, 5 to 9, 10 to 15, 10 to 14, 15 to 19, and on and on. So you can see the biggest spike there is in the young 20s. It is affecting the teens, but it also extends up into the elderly. It doesn't seem that there's really any significant population immune. These are overdose ED visits. I'll show you fatalities in a few. So this is another graph of that. We are way higher per capita. The next step down to Butte County is, at least 15% less than us per capita. I can't explain why the state data excludes fentanyl here. I don't know, but this is the data we're given. And now I will turn this over to Sheriff.
There we go.
Yeah.
Okay. Good afternoon, board. Thank you for having me here. I really want to thank Dr. Freeman. Her passion for opioids and correcting this problem within our community is very clear, and she's done a lot of work on this, and thank you for putting all this together for us. So as we go through the slides, which I'm going to present, there will be, you'll notice that the 2023 statistics are obviously lower. That's because we're obviously not through the year. So as we look at the number of arrests within our county, obviously they've gone down over the years. If you look at the sheriff's office staffing, I believe that has a direct correlation. Less staffing, less ability to be proactive and do narcotics enforcement. That's also tied to, in 2020, we consolidated our narcotics task force and moved those detectives into patrol to be able to staff patrol. If you look at the drug sales cases, clearly after 2019 and in 2020, the statistics went down. Those types of cases are traditionally made by narcotics detectives with who have additional training and skills to do those types of cases. And once we moved those folks back into patrol, they were busy doing those types of functions. And if you look at drug paraphernalia cases, it continues to be the same. It's not as low, but it is going down. And then if we look at people under the influence, again, once we lost our narcotics team, those types of cases tended to go down. They're remaining fairly consistent now, running about 16 to 22, I think it is, for this last couple years. The one big thing that I think we really lost when we lost our narcotics team is our ability to find and infiltrate drug houses within our community. If you look at what happened after 2020, we're 0 in 21, 1 in 22, and 0 so far this year. You know, that's very telling of what a narcotics team can do. And then we talk about the naloxone use. The ambulance company reported 83 uses of naloxone this past year, 20 by law enforcement. I think as you see this going up, I think you're going to see that as more staff are trained in the uses, they're better able to identify it and feel comfortable using it. You're going to see those go up, and that tends to be the case throughout the state. We look at court cases and the amount of drugs that are taken off the streets. We're seeing larger and larger amounts being taken off the street. So at a patrol level where a deputy may years ago only found a few grams of narcotics, they're finding upwards of 100 grams. Those are the types of amounts that typically you would find while doing an actual sales case and doing a complete investigation. So when we look at this, I believe this is directly related to the fact that the state has made these what used to be felonies now misdemeanors. I think that people feel that there's no repercussions for the possession, and it's a sad state of affairs. Hopefully someday the state will come back and fix that. But I do want to say that where I've talked about a lot of the numbers going down have been due to staffing. Well, there's a light at the end of the tunnel. Currently, we have 5 people in our academy. I'm going to move this over a little bit so you can hear better. And we have another 4 starting November 11th. So we'll have nine individuals in the academy. Of course, academies run about 5 to 6 months, depending on which academy you go to. We have another 3 very solid applicants in backgrounds, and then we have, it sounds like we're going to have a lateral applying as well. So we're actually to a point where I can say in the next 8 to 12 months, depending on if everything trends the same and nobody leaves and nobody gets hurt and we get everybody through all these programs and get them through training, we're going to be able to start doing some more proactive patrol. We're already starting to talk about what that will look like within our office, how we bring back a narcotics unit. Will it be strictly narcotics, or will it be more of a community-oriented team that deals with homeless and narcotics, which I think would be a great thing. But we need to get these people through the academy, off their training program, and start building back some of the things that we've lost over the years. So where I kind of feel like this was a bit of doom and gloom and things have really gone downhill for us, I think we're in a great position to start really being more proactive within our community.
A opioid presentation these days would not be complete without mentioning fentanyl. Fentanyl is incredibly deadly. The amount equivalent to 3 grains of salt can kill a person. Fentanyl is measured in micrograms, whereas we have talked about morphine milligram equivalents. A microgram is a 1,000th of a milligram, which is a 1,000th of a 1,000th of a gram. And a gram is the size of a paperclip. So it's incredibly small what can kill someone with fentanyl. There's been much, much more fentanyl, as the sheriff mentioned, locally over the last few years, as well as in the state. The rainbow fentanyl that you may have heard of is here. We've seen it in the clinics. People have brought it in. It's interesting because you can cut it open like a gobstopper. It's got many layers. It's kind of pretty. But it's here, and it's attracting the youth, which is incredibly dangerous. Unfortunately, you also may hear about fentanyl strips as a harm reduction method. And yes, fentanyl strips will detect fentanyl in a liquid substance, but people don't usually want to break up their pills. And even if they did, they might break off a piece of it that doesn't have any fentanyl in it. So they can be wooed into believing they have a safe source of their addictive substance. They also sometimes seek fentanyl. Apparently the high is quite nice. And so they use the fentanyl strips to actually get more fentanyl rather than a substance that doesn't have fentanyl added. There's a drug out there on the East Coast. I haven't seen it or heard about it out here on the West Coast yet, but it's called protonidazine, and it's stronger than fentanyl. It's also available just like fentanyl in powder, tablets, syringes. Here is our death rate in Tuolumne County. Again, going up, as might not be surprising since the overdoses have gone up. Again, starting with how fentanyl started infiltrating the substance circuit and escalating more with COVID. This is a little bit more reassuring, though. Again, maybe it's not all doom and gloom, and maybe the extra naloxone doses that we're seeing out there are helping people. The blue line there, starting 2018 through 2023, about a month ago, was where the data ends at 2023 for me. The blue line is total overdose deaths. We had 6 in 2018 and 20 in 2022. The red line is opioid overdose deaths, and the green line is fentanyl overdose deaths. The red line and the green line are not additive. Fentanyl is an opioid, so you can see the proportion of the total opioid deaths that are fentanyl deaths. Now, all of the opioid deaths this year so far were fentanyl deaths. Overall, the overdose rate, or the fatal overdose rate, is diminishing, not just here, but across the nation. There are many hypotheses about why this might be happening. The fact that naloxone is out there more, it doesn't necessarily mean the use is down, but it does mean that people are dying less, which is good. And who's dying? This is preliminary for 2022 data. And again, by years of 5-year increments, the first line we see there is 25 to 29, then a little higher in 35 to 39, highest in 40 to 44, and then 60 to 64 and 65 to 69. Those were our deaths in 2022 from opioids. The highest rate being in people who are parents, probably, leaving their children without a parent. You may or may not have heard of xylazine. If you haven't, here you go. Xylazine is a veterinary medication that's out there on the streets now. I don't know how it's getting out there. There is no way to commercially buy it unless you're a veterinarian. It is a clear liquid, and it's being mixed with drugs. It's being mixed primarily with opioids, but it can be mixed with other drugs. With the opioids, it extends the high. It is a tranquilizer. The doc last year used it on my horse when he got stitches in his eye. It's amazing, really. The horse stood there and got stitches in his eye with no problem, and then he came out of it. He was in a trance. He literally was in a trance on his feet with a little headrest. It was very cute, for about a half an hour while she sewed him. But this is coming into human populations. The biggest risks of it is when they put it in their drugs, now they're actually kind of comatose. The drug's doing its job of making them high and what have you, but they won't move. So they'll be sitting on a park bench, maybe slumped over their legs, and when they wake up a few hours later, now they haven't had any blood supply to their legs and they need amputations because they're dead. So it's creating all kinds of issues otherwise medically, and so it's something to be aware of for sure. The other thing it does is cause some skin necrosis. It's really the only way to find it clinically right now. We don't have a great way to test for it in the emergency department or even post-mortem. We have to be suspicious of it. There's not really much we can do about it except wait for the person to come out of it. These people are also becoming victims of crime. If they're out there on the streets using and they're comatose for a few hours, they're possibly going to get assaulted or stolen from or what have you. So it can affect law enforcement as well for that. A little bit more about it. It causes the coma, but it also causes a low heart rate, a low blood pressure, very drowsy, and then there's abscesses all over the body, not just where they inject it. So something to also be aware of, and may be a background to what we have as our crisis here and why it's so important to intervene, not just to save the lives of the people using now, but to save the lives of the next generation. If you're not aware of ACEs, that's short for Adverse Childhood Experiences, it's really important to get aware of this. You can find a lot of information online. There's a simple 10-question questionnaire, and doctors are now rolling this out into their population and discovering what a person's background might be. If you want to learn more about it, it is based on a study done about 20 years ago, I want to say, maybe longer, in several thousand patients. They were Kaiser patients, so it's a population that is not necessarily reflective of a true community. Nevertheless, they had good follow-up with that, and they could say that, you know, most people in that population had at least one ACE, and that was okay. They didn't have detrimental effects from that. But if you had 4 or more ACEs, you are more likely to have many bad medical outcomes, especially amongst addiction, anxiety, and depression. So one of the ACEs is actually whether or not your parents use drugs. The ACEs are all from 0 to 18. So certainly you can have traumas and other adverse events after that that can predispose you to using, but this is all for young people. So one of the ACEs is whether their parents use drugs. If we can intervene at any point, we can potentially make our next generation healthier. These are some of the things, the health conditions that come from the ACEs that they have seen. You know, the biggest one there, if we didn't have as many ACEs, we'd have 44% less depressed adults, 27% with less COPD, which is from smoking, 24% with less asthma, and it goes on. Obesity would be less. Unemployment would be better. Getting more education would be better. Those things all have been reflected that if you have a high ACE score, you're less likely to have good outcomes amongst all your health outcomes and social outcomes and health risk behaviors. ACEs are many things. Again, I encourage you to go look at it. I also encourage you to look at the 15-question resilience questionnaire. Paired together, they can really tell you a lot about whether or not a human who has experienced a lot of ACEs may be successful. There's a lot of people out there with high ACEs amongst us. In fact, the people who go into healthcare careers tend to have ACEs because they're trying to fix their childhood. So there are a lot of people out there that have ACEs and are doing just fine. And that may be a result of the resilience. There's not a lot of data on that, but it's definitely worth looking at. These are some of the things that are included in ACEs, a lot of which nobody can control. Whether or not you were a victim of a wildfire, for instance, is a huge trauma, whether you're an adult or a kid. So knowing about these things and doing what we can as a community and as healthcare providers can help control these bad healthcare outcomes, including addiction. This is now available. It's from the Office of the Surgeon General. It's a 2-hour instructive course available for free. All of the teachers and health and care providers, child care providers throughout the state are supposed to at some point do this. I'm not sure when it will be mandated, but it's now available. There's 3 different modules for addressing 0 to 5, 6 to 12, and 13 to 17 age group. You can stop and start wherever you want. So you just get on there and go 10 minutes at a time. You can learn more about ACEs and how it affects certain childhood ages. So another resource to look more into that. And then I alluded to this earlier, and so I wanted to update that there have been some very positive changes this past year. Last November, the CDC released a 95-page document on guidelines for practitioners on when to start, when to stop, how to evaluate opioid use, that were much more conservative than previous guidelines. So hopefully this will help our practitioners fall within that and try to get patients with that in that, and as well as search for other pain control measures. A lot of people have not been exposed to the other things they can do besides opioids. And so on a patient perspective and on a provider perspective, it's really important to know all the resources you can use to help control pain. The DEA earlier this year stopped the X waiver required to prescribe buprenorphine. So buprenorphine is an opioid, but it does not cause respiratory depression. It's almost impossible to kill someone with it. We had somebody come into the emergency department who was pregnant and had taken half a month's worth, and she and the fetus were fine. So it's much safer. It is an opioid. It is a substitute, but it's much safer. It used to be required in order to prescribe this that you needed to take an 8-hour course, which in my opinion was completely ridiculous because I didn't need that to prescribe Percocet, and I can kill you with Percocet, but I couldn't kill you with buprenorphine. I can kill you with insulin or with potassium, but I needed 8 hours to learn about this medicine. Anyway, that's been dropped, so hopefully that will reduce the barriers for providers to become more educated about it and use it. We have a substance use navigator now at Adventist Health Sonora. That person is taking in the patients that come into the emergency department, overdose, withdrawal, maybe on high doses, and helping plug them into resources locally so that they can get more access to other ways to control pain or other ways to treat their addiction. We also, just a few weeks ago, brought the Opioid Coalition back to the county after it had been at Matheson for a couple of years. And we're moving forward with community partnerships and regional partnerships in educating and discussing amongst anybody who wants to be a part of that, what's going on and doing things as a team to try to address those locally. Other things on the horizon, we are getting the opioid funds from the litigation distributed into the county, and we are in the process of community surveys and creating a document for you, board, on what we would recommend those funds go to. So we're going to be coming back to you in the near future with that information for your guidance. We also have the local indigent care needs van, which will be on the road very soon. And on that van, we will be offering addiction resources, including getting patients into addiction clinics and even short-term prescriptions for the time they need to get there. Naloxone is coming to the county soon. I have gotten the order approved a couple weeks ago, so I'm just waiting for the shipment to come. So at that point, we will be able to get county employees and start distributing to the public. More to come on that. But these are all positive changes happening right now. Other things I would encourage anybody to do, as I was mentioning earlier, learn about the ACEs, learn about what might be going on in the people you know and the lives you touch so you can help those. On the resilience questionnaire that I mentioned, the one thing that's most important is that those kids have an adult they can trust, a coach, a teacher, a neighbor. So recognize that your role might be that you're that person, even though you don't know the ACE score of your next door neighbor. Advocate for non-opioid pain control options. Get naloxone, or anybody you know can get naloxone. They can walk in and get it at any pharmacy. It's supposed to be on the counter soon, like next to the Tylenol. Just get it and run out with it after pain. It will be free from the public health. It is free at Matheson, so people can go in and get trained and get their supply. These are our references. What questions do you have?
Well, we'll ask our board if they have questions for you to begin with. Does anybody have any questions? Just comments? I think I have one. I think I marked something back here. On slide number 5, you had mentioned that other counties are improving at a faster rate than Tuolumne County. I'll wait until you get there. It's a history in Tuolumne County. There we go. So when we got to this slide, you had mentioned that, we've been #1 for 5 years and other counties are improving at a faster rate. So what have you been able to find out so far that they're doing that we're not doing?
I don't have a good answer for that. It's definitely a question I'm asking, but I don't have a good answer for that. It seems that possibly, and again, this is kind of more hearsay than it is a scientific answer, that many places were much harder on the patients in the transition off of narcotics. So the providers would get direction from their administrators that they must, fall within a certain prescription parameter or get fired. That hasn't really happened around here. There's been a lot more freedom to do the practice that you believe you should do. And I'm not saying that's good or bad. It is not necessarily the best thing to do to get people in withdrawal. So I believe other places have been more strict about what their providers are doing, and coming from the administrator of facilities, but I'm not sure that that necessarily was the best way to get their numbers down. There are great ways to get numbers down. We could have gone faster and better, but I don't have a great answer otherwise.
Just curious. Thank you.
It's a good question.
Yeah. Our board doesn't have any other questions that I'm seeing, so I'm going to take this to the people that are here in our audience to see if anybody has any comments or questions for our presenters today. Good afternoon.
Thank you. I saw this presentation last week. I thought it was fabulous. I encouraged a lot of people to come here. I'm sorry they're not here. I think this is very important information. This is a very pervasive problem in our community, and I think we need to take a really good, strong look at this. I've been advocating for the return of the Narcotic Task Force since it disbanded. We need to look at alcohol too, but that's another issue. I know with the modernization of the MHSA, they're including substance use disorder to a greater degree. And some counties have not only a behavioral health advisory council, they're instituting a tobacco and alcohol substance abuse committee too. So we might want to think about that. And our local law enforcement, probation, behavioral health, social services, they all carry Narcan. CHP is not allowed to carry Narcan in the state of California unless they have an agreement with a particular jurisdiction and they're helping with drug control. So our CHP does not carry Narcan despite their involvement in drug searches. So I think it would be really good for us to advocate at the state level for our CHP to be allowed to carry Narcan. Their number one super duper commander in Sacramento explained it to me that it has to do with the fact that CHP often crosses jurisdictions. But Narcan is available over the counter now. Unless you're on opioids, it's not going to harm you, and the only harm you're going to get is the fact that it doesn't last as long as the opioid, so you could go into withdrawal again. And so when you give Narcan, you need to call 911. So if you can give it over the counter and you're covered by the Good Samaritan law, I don't understand why our CHP cannot carry Narcan. Thank you.
Thank you.
In response to that, my EMS director role, I am advocating at the state level for CHP to carry Narcan. And when we get our local supply, we may be able to work something out with our local CHP. So we're in discussions on that.
Great. Anybody else from the audience? Yeah, come on up. Hi, welcome.
Good afternoon. Thank you for the information. It was very helpful. I was not aware of the significance of the problem here in our county. I've been here 5 years and kind of been doing other things, but I was wondering if we had any information that stated the number of people that we have. Are they primarily long-term permanent residents of the county, or are we finding people coming from other areas that are temporarily here, unhoused people? I mean, just wondering if we know any of that information.
This is available. I can pick up a handout on the references page on the Skylab state site. You can also just search California opioid dashboard. You'll get to it. You can get into incredible weeds there, including by zip code where the prescriptions are.
Okay.
So it's for prescriptions in our county to county residents, people who have an address here.
Okay.
That's where these data come from.
Okay, thank you.
Thank you. Seeing no other public comment, I'll bring it back to our board for their comments. Supervisor Brandon.
Great, thank you. So Jansen, McKesson, Marisource, Bergen, Cardinal Health, Johnson & Johnson, Teva, Allergen, and of course Purdue, our favorite that we ended up suing as well. Created a whole cadre of basically legalized international drug dealing within the United States that has created a generation of addicts. And we are part of two particular areas of the state that are hit incredibly difficult with the opioid epidemic. We're in that third wave of synthetic ones, which is incredibly scary. So I want to thank the sheriff for presenting on, I think, the results of a lot of the investments we've collectively made to see that we are recruiting, we are rebuilding our proactive law enforcement force, that 8 to 12 months we can hopefully begin having conversations about restoration of some of that. I think that's incredibly important. I know that we share this, we've heard it from the public as well. Restoring the Narcotics Task Force is a top priority for me. I also want to say thank you, Dr. Freeman, too, because I know that you have been working not only in tracking this data and trying to share it to the public, but working to educate our medical community, and that's incredibly important, too. As you mentioned, people were taught wrong. They were taught based on what was, I guess, assumed to be the best knowledge at the time, and they need to be retrained in that. We've seen probably bad actors in that system, but we also want to make sure that the good actors have the tools they need to do it. And I also want to thank our district attorney for aggressively pursuing these cases and looking into the idea of additional manslaughter or murder charges as well when it comes to a dealer that is dealing, especially fentanyl, where the state is not giving us the tools that we need to be able to prosecute this at the level it should be, that we at least have something to make them responsible for the outcomes that they're creating within our community. I was typing here, I did a little fun math on it. About 1 kilogram of fentanyl could kill about 500,000 people, meaning it would take about 66 kilograms to kill everybody in California and overdose them. I weigh about 81 kilograms. If I was made of fentanyl, and that's not huge, you know, put me in the back of a car, right, or whatever, that's enough to overdose every American on the West Coast in Oregon, Washington, and California. That's an incredibly scary, I think, comparison of when we're trying to deal with this, how different this is than other drugs, and how we have to get that out, because it can be in any pill, as you mentioned, it can be in any substance. And we probably have a lot of people that are looking for an alternative. As we crack down on one issue of prescription opioids or heroin, we're dealing with this other one of people that are still in recovery, will be for many, many years. At least what I've seen from this and then online has been that fentanyl's replaced something like 85% of a lot of the opioid overdoses within the state. And so while we are not post that crisis, but seeing a lot of progress made, this is really that next step. I know that the state's put $1 billion into opioid funding, $416 million of that from the general fund, some federal, some lawsuit money. But one thing I would hope would come out of this is that we're able to talk about the fact that we need money for enforcement, and we need money for, I think, recovery options that aren't just Narcan. I look at it that Narcan is a Band-Aid. It's like trying to stop heart disease with defibrillators. You know, you want to have those in the room, obviously, but that's not going to fix the root problem. And I know that's a hard discussion where the politics are at the state, but it's killing people. And all we're doing is treating the symptoms of that to try and help people recover, but we need more tools to be able to bring that back. I hope that whatever we can do to work together and with the Opioid Coalition to identify that and show our state legislators know that, the governor's office knows that. We should use the fact that this is for no good reason, very high county in this, that they need to realize just how bad it is here, and maybe we can make some good come out of that. I also want to highly recommend something that was presented at our, I believe it was the recent RCRC conference, was the One Pill Can Kill campaign that Placer County has implemented. So in addition to looking at the murder charges that can be added into dealing that leads to a death of somebody, the One Pill Can Kill, I know we've had education campaigns in the past. We talked about that at the Behavioral Health Advisory Board meeting. But the idea that we can pull together law enforcement, prosecution, public health, education campaigns into something that really gets that message across, that is not just education, but it's education on what we're going to do for enforcement as well. And I think the Opioid Coalition being under the county, that is an opportunity where we can pull all that discussion together. and I hope we can do it. One of the concerns that I have is, since our staffing changed with the district attorney's office, one of the things that was dropped and I brought up was the fentanyl awareness campaign. And I really want to see that have a new home, whether that's between law enforcement, behavioral health, and public health, or one department there to kind of take lead. I think that's incredibly important. People don't know, besides what we see in a 30-second segment on TV, just how pervasive this is and what the actual human cost is. And I think we need to do our best to get that out there. Last little point on it is I would encourage back, while we have this opportunity, and this was a very good presentation, I think anybody watching should try to get a hold of this and see the data on what this looks like. Any direction that you would be looking for on potential things to bring back to the board that can address this while we have this. We only have so many opportunities with most of us up here to be able to provide that feedback. And I'd be interested in what those recommendations would be, and hopefully some that we might be able to give our preference or direction on. So thank you for being here today. I appreciate it.
Thank you. Supervisor Goldenberg.
Yeah, thank you. Good presentation. A lot of information here. There's some question marks, right? Because we don't fully understand the reasons why Tuolumne County has some of these levels that we do. Encourage to keep digging. I'm not sure what type of communications network, Kim, you have with the people that prescribe in the county, and how you reach to them. Is there like an official channel that you have for, like, if you want to reach out to all prescribers, or if not, maybe that's something to consider? Or
There isn't a great channel currently. Our medical society got disbanded several years ago, and that's something I'm interested in re-implementing, so that there is a place for practitioners to have a forum, to come together, to do all kinds of things, not just about opioids, but it would be great to have more practitioners here. Maybe if we had a more welcoming environment and more providers, bringing those people in and welcoming them, we could retain some people. There's lots of potential ripple effects of creating a medical society. So that's on my radar. Otherwise, I am getting out into the clinics. Tomorrow I'm going out to MACT to spend lunch there and talk about this as well. I've been out to Miwok, been to the primary care at Adventist. I'm going to Matheson in a couple months.
Well, that's good. And your passion for the subject is very strong, and I myself, and I know the rest of the board probably agrees with this wholeheartedly, is continue those efforts, because it's important. One of the things when we have public comments, people get up and they bring things to the table. They ask questions that I didn't think to ask, or was not aware of. One of them, quite honestly, that I'm not familiar with is, what is a narcotic passport? Was that how it was posed? Task force.
Task force.
Okay, I thought I heard passport at one point.
It is similar.
Okay, yeah, okay, I know the task force, okay. So I missed that one. On slide 6, the pain, the 5th vital sign, I can't think of a time, and whether you're in a room privately, with a practitioner of one sort or another, or you're in an ER, or maybe, a clinic where there's other people around, and it's always asked over and over, what's your pain level? What's your pain level? And it's, I think the tendency is, for people that are looking to obtain something more, it kind of encourages them to inflate their pain levels so that they get something or get more of something. And that, again, can be something to be looked at, more in the future, to...
Yeah, there are some institutional barriers that now are kind of ingrained, one of which is that it used to be that nurses got their wrists slapped if they didn't ask.
Yeah.
They got in trouble. And if they asked and the number was a certain level, they'd wake the doctor up at 3 a.m. and say, you got to treat this pain. So, this created a cyclone of lots of asking and lots of I wouldn't say over-prescribing if somebody's in the hospital, but over-ordering so that there could be orders though that phone doesn't ring at 3 in the morning.
Interesting. Okay, thank you. That's all I have.
Thank you. Supervisor Campbell.
Thank you, Dr. Friedman. Thank you, Sheriff, for your very sobering and unfortunately informative presentation about this critical issue in our community that I think this board, we're not very surprised by, because we've been living with this and dealing with some flavor of this problem for a very long time. I can remember my first foray into county government was as a behavioral health staff services analyst. And one of my first tasks was to look at data related to, so it was called AOD at the time, but it was basically drug rehabilitation programs. And it was bizarre to see an increase in opioid-related treatments, because at the time that was seen as a high class, or I'm sorry, the other way around. It was seen as, people that were addicted to opiates, those were heroin addicts. They were people that were living in urban areas and the street corners in Skid Row, not Little Tuolumne County. And of course, since that time, it's become more or less the drug of choice. So I'll tell you a story, and then I'll ask you a question. So just to kind of hammer home how much this touches the lives of all of us, whether we know it or not, I was driving my children to school about a year and a half ago, driving them up the hill. And just right down the street from me, I see lights and sirens parked outside of home. And so I dropped the kids off at school, and being the nosy person that I am, on the way back, I pulled in and kind of asked the neighbors what had happened. And it was somebody that I don't believe I knew them personally. It's possible that I had met them at some point, but somebody that was in their mid-30s, neighbor of mine, died of a fentanyl overdose. And nothing, there's no distinguishing element to this person's life other than the fact that they had some pain issue at some point in their life, and then they became addicted to prescription pills. So that's just to illustrate the fact that it can happen to anyone at anywhere in any community. It's almost as though opioid addiction is like a bolt of lightning. It just strikes people almost at random ages, random types of communities. And so that's the frightening thing about it. But the question I wanted to ask you is that the nature of although the numbers have improved, and I would say kind of the nature of the addiction issue has changed a little bit. I remember in years past, not too long ago, a lot of the overprescription issues were related to maybe one, maybe two specific doctors. Doctors who have been talked about here by our district attorney. And I know that that's no longer the case, but is there something to be said about that? I mean, should we be looking at what part of the medical industry should we be looking at? Because, are we talking about the illicit prescriptions where, people are getting it illegally, they're producing it illegally? The doctors have basically no part of that equation. But there's also this other conduit where it's legal prescriptions, but they're being given to a grandmother, and then the teenagers take it, or there's a whole variety of ways people can get past that gatekeeper. So is that an area that we can look at to at least move that needle in a positive direction still? Because even though we've gotten, I don't want to say gotten rid of, even though the particular doctors that were severely overprescribing this in years past are no longer practicing in our community, is that still an issue? So that's the question I wanted to ask you.
So there's multiple questions here. On the issue of finding out and trying to target where education might help providers most, I'm working on it. I've been trying to get deaggregated data from the DEA. Been working on it for over a year. We're hung up with IT, trying to get the final push of stuff that they're requesting again, because we thought we were done in August. Once I am able to get that data, I will know I won't know who, but I'll know, say, dentists in 95370 are prescribing, X amount, and orthopedists in the same zip code are prescribing this amount, and family practitioners in the Jamestown, I'll know a little bit about who and where things are prescribing, but I won't know who. Okay. That can help. I might know that there's a certain facet of providers or a certain location that I should target as far as education goes. So I'm working on it. I'm hoping to get, every day I'm hoping that information comes, but we're still waiting. I do want to point out, though, on this graph of the MMAs per resident, we can look at any point in time. So stock was apprehended in 2016. We have different areas on there where we know somebody left practice. And there isn't that dramatic of a drop that can say that one practitioner really drove this. Or that is even still driving it. I think there's still a culture around here of prescribing, and part of this is patient-driven. I do know of so now I get to tell stories. There's a doc here who came in 2012, and he told me last year that when he came and opened his practice, family practice, he was appalled by the prescriptions that people had when they came in to establish care. He didn't want to prescribe like that. And his colleagues here told him that if he didn't prescribe, he wouldn't be able to get his doors open or keep his doors open, that nobody would come, that he wouldn't have patients. That was only 10 years ago. Things have changed. Patients are more seeking more different avenues of care and not seeking the opioids as much. But that is the culture that has been based here for a long time, that, you're going to prescribe and the patients will get mad at you.
Yeah. And just kind of on that point, what I'm looking for is there a way we can find out what should be the average prescribed, milligram or morphine equivalent per doctor, say, and if they are outside of that average, are we able to ask them why? Everybody is going to have different clientele, and there may be a legitimate reason to prescribe more than what that average should be. But do we have a tool to at least ask the question?
I can ask the question. I don't have data to target that yet. And yes, different facets are going to be different. Surgeons and orthopedists are going to have post-surgical pain they need to treat. In primary care, the average amount of pain management in your primary care practice is 10%, but some practices have more because that's been their tradition. Things have been changing, but I'm hoping that at least within certain facets, I'll be able to get more information. I can't say that there's a guideline out there that says you shall prescribe only this amount for this kind of person for this kind of pain. That isn't really out there. There's autonomy to do the best for your patient. But the CDC guidelines do outline that you shouldn't do, another level up unless you've done this, that, and the other. Make sure that they're going to physical therapy. There's lots of adjuncts. So there are guidelines from the CDC that tell you how to gauge whether or not your prescription is appropriate. But other than the 50 morphine milligram equivalent ceiling that they're putting on it, there isn't otherwise a hard and fast rule. Does that answer your question?
Yeah, I think it gets to my point that we don't really have enough ability to acquire that data to look into our local community. We can get the big picture numbers, of deaths and overdoses and law enforcement involved individuals. But what I would be interested in finding a method to is going one step back to how prescriptions operate in our county and down to not necessarily the individual person, but at least the individual healthcare provider. I don't think that's an unreasonable thing to ask maybe some of our local health care providers to work with us on.
Yeah, so I think that continuing my outreach into clinics and trying to get a medical society going and such, I will be able to get more information, data on what's really going on in the community and what challenges people have. And I would say that it's not just the practitioners, but it's also the patients and their expectations. They expect to go and get pain medicine, and if they don't, they complain. And if a doctor gets complaints, then they have to go into an office and justify what they're doing. And there's a bit of culture all around it, both on patient and practitioner and administrator sides, that really need to change. Especially if a practitioner is getting any kind of bonus based on patient satisfaction scores. It's very difficult to argue with patients, even though it might be in their best interest.
Yeah. Well, thank you very much. And Sheriff.
Supervisor, you had made the comment earlier on in your statement about basically kids getting their hands on these types of drugs through the grandma's medicine cabinet or whatnot. I'd be remiss if I didn't throw out a shameless plug. The 28th of this month, from 10 o'clock to 2 o'clock, we're doing the drug take-back days. So if anybody out there has these types of prescriptions or any prescriptions at all that they want to get rid of, please bring them down to the Sonora Library, and we'll take care of those for you.
And that was what day? October
28th.
28th.
Yep. From 10 to 2.
Thank you, Sheriff. Thank you.
So I don't have any other comments other than those that my colleagues have made. I really appreciate this presentation from both of you. I'm hoping that our Access to Tuolumne can possibly show this as a separate thing. I mean, they always show our board meetings, but I'm thinking this is so important for the community, for their awareness and their education, that I'm going to propose that they show it separately as a standalone for them to get educated on. I think it's that important. And thank you for being here today.
Thank you for having us.
All right, so the last thing that we are going to be addressing today are three closed sessions. And Heather, would you please read all three of those?
Item number 1, closed session, conference with legal counsel, anticipated litigation, Government Code 54956.9 D2 and E1, one case. Item 2, closed session, conference with labor negotiators, agency representatives, Tracy Riggs, County Administrator, and Sarah Carrillo, County Counsel, unrepresented employee, Animal Control Director, Authority Government Code Section 54957.6. Item number 3, closed session, public employee appointment, Authority Government Code Section 54957B1, Animal Control Director.
And Ms. Carrillo, do we expect to report out on any of these? All right, so I will adjourn our meeting. Oh, yeah, I always forget that for some reason. I do need to ask for a public comment on our closed session. Is there any comment on any one of those? Seeing none, okay, now I will close our board meeting I adjourn our board meeting at 2:34. Recess. I don't adjourn it yet. Recess, so we can go into closed session. All right, thank you.